Hello, my name is Sean O'Leary. I'm a professor of pediatrics at the University of Colorado School of Medicine and Children's Hospital, Colorado, and I'm the chair of the Committee on Infectious Diseases for the American Academy of Pediatrics. And I'll be talking with you today about the American Academy of Pediatrics HPV vaccination guidelines. I have no disclosures. This slide reflects the AAP recommendation for HPV vaccine as seen in the Red Book. The American Academy of Pediatrics and the ACIP of the Centers for Disease Control and Prevention recommend routine HPV vaccination for females and males. The AAP recommends starting the series between 9 and 12 years at an age that the provider deems optimal for acceptance and completion of the vaccination series. The ACIP recommends starting the series at 11 to 12 and states that the vaccination can be administered starting at 9 years. So what prompted the difference in recommendations? Both ACIP and AAP recognize the vaccine is safe and effective and that it prevents HPV infection with the consequent prevention of anogenital warts, respiratory papillomatosis, cervical neoplasia, and cancer, with data on the impact on cancer becoming more robust with each passing year. However, despite its remarkable safety record and high effectiveness, HPV vaccination is well below national goals and lags behind other vaccines in the so-called adolescent immunization platform, which also includes tetanus, diphtheria, acellular pertussis, or Tdap vaccine, and quadrivalent meningococcal vaccines. The most recent National Immunization Survey teen showed that the uptake of Tdap vaccine was 89.6%, and the first dose of MenACWY meningococcal vaccine was 89%. HPV rates remain significantly behind these vaccines, with initiation at 76.9% and completion at 61.7%. There are multiple reasons to increase HPV vaccination uptake. In contrast to vaccination coverage, the burden of HPV-related mortality in the US far surpasses the mortality from tetanus, diphtheria, pertussis, and meningococcal disease combined. In the US, there were roughly 4,000 deaths per year from cervical cancer alone, not to mention the mortality burden from the other types of HPV-related cancers. Mortality data for some of these other cancers are not systematically tracked. The vast majority of these deaths are preventable with the 9-valent HPV vaccine. Thus, there was and continues to be an urgent need to increase HPV vaccination uptake. With this in mind, the Committee on Infectious Diseases, on behalf of the American Academy of Pediatrics, considered policy options that could increase HPV uptake and ultimately decided to recommend starting the series between 9 and 12 years. There were several considerations that went into this recommendation. The first was flexibility. Offering the vaccination earlier offers providers flexibility in introducing the vaccine. In addition, another consideration was that there would be fewer shots per visit. Initiating the vaccine at age 9 or 10 may be preferable for parents or adolescents who do not want to receive 3 or 4 in influenza season concomitant vaccines at age 11 or 12. And remember, with COVID-19 vaccination, this could mean as many as 5 vaccines recommended at a single visit. A further focus, of course, was a focus on cancer prevention. Some providers reported that initiating the vaccine earlier made it easier to disentangle the HPV recommendation from discussions of sexuality. Another consideration, of course, was vaccine hesitancy and what I will call recommendation fatigue. Changing the timing of the recommendation might address the hesitancy portion of it and also potentially could address the fatigue that some physicians experience when recommending the vaccine. We know that many physicians defer recommending HPV vaccine at age 11 to 12 because they assume parents will refuse. Finally, we wanted to look at the history of the adolescent immunization platform. We couldn't identify any evidence supporting the practice of starting the recommendation at age 11 or 12 within the so-called adolescent immunization platform. In fact, we felt we had evidence against the strategy given the low uptake of HPV vaccine. Initiation at 11 or 12 is rooted in the concept of the aforementioned adolescent platform of vaccines. This adolescent platform concept, stressing the importance of the 11 to 12-year-old visit, was introduced in 1996 and has been the heart of messaging campaigns promoting adolescent vaccination from CDC, AAP, and others. In 1996, well child visits beyond kindergarten were relatively uncommon. So CDC, AAP, and the American Academy of Family Physicians, or AAFP, wanted to establish an 11 to 12-year-old visit for catch-up on routine vaccines, particularly hepatitis B vaccine. 20 years on from that recommendation, though, the AAFP and AAP were routinely recommending that children have a well child visit every year, and the vast majority of children, 79% roughly of 6 to 11-year-olds were doing so. Thus, the 11 to 12-year-old visit no longer carried the importance it once did. For the HPV vaccine specifically, ACIP's initial recommendation in 2007 for vaccination at 11 to 12 rather than at age 9 years was also based on concerns regarding potential waning immunity. Although HPV vaccine had been licensed down to age 9 with excellent immunogenicity and safety, duration of protection was a relative unknown at that time, so ACIP also considered age 11 or 12 as a good middle ground for vaccination, prior to sexual debut for most adolescents, but close enough to provide protection through the highest risk years. It has become clear to us within AAP, however, that the bundling approach was failing for HPV vaccine. When a vaccine is delayed at the 11 to 12-year-old visit, it's almost always the HPV vaccine, despite the fact that deaths from HPV-related diseases in the US exceed deaths from the other diseases prevented by adolescent vaccines by orders of magnitude. Now, we also have strong evidence that HPV vaccination offers durable protection, further eroding any justification for waiting until age 11 or 12. The immune response is robust at younger ages, and there is no evidence of significant waning after antibody levels plateau approximately 18 to 24 months after series completion. What about data suggesting that a strategy of earlier initiation would lead to higher HPV vaccination uptake? At the time of our discussions, there were no randomized trials that compared introduction at age 9 or 10 years to introduction at 11 or 12 years. There is currently a large trial ongoing now with results expected in the next few years, but we still don't have randomized trial information. We did have, however, at the time, some observational data supporting earlier initiation. A retrospective study showed that adolescents who started the HPV vaccine series at 9 or 10 were 22 times more likely to complete the 2-dose series by age 15 than those who initiated these series at 11 or 12. Other observational studies also showed promise for earlier initiation. A report on a quality improvement initiative performed at the nationwide children's hospital system using electronic medical record alerts showed rapid uptake of HPV vaccine prior to age 11, suggesting a willingness by parents and providers to initiate the vaccine earlier than previously recommended. Subsequent to our deliberations and the change in our AAP recommendation, there have been other studies demonstrating both the promise of earlier initiation and provider willingness to do so. Ultimately, the goals of ACIP and AAP with regard to HPV vaccination are the same: to prevent HPV-related diseases and cancers. The AAP policy encourages pediatricians to introduce the vaccine at an earlier age to achieve higher initiation and completion rates. This, however, is but one of many strategies AAP encourages to increase uptake of HPV vaccine. For example, reminder recall, use of standing orders, and use of presumptive recommendations for vaccines. There is no one single intervention that will bring us to 100% uptake, but we believe that by combining multiple evidence-based strategies with earlier introduction, we can make significant progress toward eliminating HPV-related cancers in the US and beyond. And I will close there sharing some resources. The AAP has an excellent website with a lot of immunization resources. You can see specifically for HPV. We also have information about HPV and HPV vaccine on Redbook Online. We also have some on our general immunization page, as well as an interesting interactive vaccination map. And there is information on HPV vaccine and HPV disease on our parenting website at healthychildren.org. And with that, I will close. Thank you.